Thank you very much, all of you, for being here into the wee conference hours. I hope you're really going to enjoy this. We're going to talk about 5 things you might want to consider no longer doing when you're caring for children. And so one of them is going to be to stop using albuterol and steroids to treat bronchiolitis. We're going to think about how maybe not every single apparent life-threatening event that comes through your door needs to be admitted. We're going to stop making fever hurt by no longer poking children who are well-appearing when they come to our departments with fever. And we're going to maybe even consider not doing a lumbar puncture in all of the 4 to 8 week age children who have fever and present to us. And then finally, we're going to try not to decide to not incise and drain a skin infection without at least looking first with an ultrasound. So let's start with bronchiolitis. Oh my gosh, mucus factories, right? If we could teach babies to blow their noses, this would not be as much of a disease. But we don't know how to do that, and so we see a peak incidence in months 2 to 5 at a time when they're still teeny tiny and parents get really, really upset. Luckily, there's a pretty low mortality, but there's a lot of ventilation perfusion mismatch that's happening there. And when we come to taking care of children who just have mild bronchiolitis symptoms, then we know that, well, first of all, controlling the rate of tachypnea by taking care of their fever really helps. But then the big intervention we can have is suctioning. And I'm a big believer in using some sort of pulmonary index score that objectifies to some degree how much dyspnea the child is having and how hydrated they are and those types of things, and then looking to see if some of those symptoms are relieved after you do nasal suctioning. Then I educate the parents. This is going to be a home care kind of situation where you're going to also be required to do lots of suctioning. And I'm going to tell you the types of things that you really need to return for. And I'm going to focus on things like starting to get dehydrated, starting to look tired, having signs of real dyspnea even after the parents do nasal suctioning. And then I'm going to tell them this is a really long disease. Some kids have symptoms for 5 weeks, and half of children who have it are going to have symptoms for at least 2 weeks. So I need to kind of reset their expectations. This is not going to be like every little cold their other child had. These symptoms may linger for a while, and it's going to be kind of labor-intensive for parents. But when it comes to the care of moderate to severe bronchiolitis, is albuterol helpful? Well, some meta-analyses, actually pretty extensive meta-analyses, suggest it probably is not. Albuterol does not reduce hospitalization rate. It does not reduce the length of stay when you are hospitalized. It may decrease your pulmonary index score if you're using one of those sort of more objective measures, and it's statistically significant. But I'm not sure that a decrease in your clinical score of 0.42% is something that's clinically significant for me. Albuterol also doesn't change things like your oxygenation status or how long you're going to have those symptoms once we send you home. But it does have side effects, and it does cost money. And I really would venture to say that it does kind of take the emphasis away from the things that the parents can do that are most effective, which is pushing fluids, feeding frequently, even if the child can't handle as much, and performing a lot of nasal suction. Now, similarly, steroids don't have the impact or the punch we were hoping for. There have been lots of different trials that look at inhaled steroids, intramuscular, or intravenous, oral, and basically when you compare them to placebo, there's not a difference in whether or not you get hospitalized, whether or not you come back and need to be hospitalized in a day or a week. There's not a lot of difference in your clinical parameters like respiratory rate. There is one study that suggests that if you bring the children in for a period of observation with their moderate or severe bronchiolitis, that you're discharged from that observation unit a little bit earlier. But the study was positive only in children who were considered to have a very high risk of asthma, either because they had first-degree relatives with asthma or because they themselves had an incidence of eczema. And it really only had its truly beneficial effect in kids who were getting albuterol. And look at how much albuterol they gave. They gave at least 4 doses. And the children who got epinephrine in addition to that albuterol. And I just don't think this really represents what the literature is suggesting is best management of bronchiolitis at this point in time. So I think steroids don't have the punch we're looking for. Okay, now here is a really cool study. And I just love the implications for us when we're managing kids with bronchiolitis. These guys took a group of bronchiolytics and randomized them to either have their pulse ox read accurate